Hi there. I'm going to do the Special Populations Child and Adolescence chapter of the book right now. And I'm sharing my slides. Okay, so I encourage you to read this chapter on your own. So that's the case more so with these last 4 chapters than some of the previous chapters that I have gone over in terms of specifically pharmacology stuff. So, but I did pull out the salient parts that I would like you to leave with. So hopefully if you do both, you'll have kind of a robust understanding of the material. So in children, therapy is usually best, and the majority of emotional suffering experienced by children is situational, okay? So it's responsive to something in the environment or in the home, and therefore it responds best to non-medical and often psychological treatments, for example, family therapy. However, 33% of cases of OCD and up to 15% of cases of bipolar disorder have childhood or early adolescent onset. Okay, so therapy is usually best, but in some cases, medication is recommended. And then in particular, pharmacologic treatment of these disorders, OCD and bipolar, may not only be successful in terms of improving symptoms, but may also be neuroprotective, okay? So there's also this whole argument that delaying medical intervention when pharmacologic treatment is the best route might cause further damage to the brain that would be a result of letting the disorder progress untreated. And so there is evidence that medicine is one of two things, either protecting against damage from the disorder or at least buffering in a way that allows normal maturation that will prevent any further progression of the disease. Okay, so in particular on this last point, there is some evidence showing that medical treatment can help offset neurobiological impairment, okay, in these disorders because of their corresponding evidence of progressive neurobiological impairment. Okay, so they include bipolar, ADD, schizophrenia, some cases of recurrent depression, and some cases of PTSD. All right, and now, of course, there are concerns with pharmacologic treatment in children. And one primary one is that there is no real informed consent because the parents are making the decision. And so a real effort should be made to include the child as young as possible. And they in the book, they consider that at the age of 7 or older. And there's this other concern that really gets complicated throughout the chapter, and hopefully you'll catch on to that as well. But in general, when prepubescent, the normal rate of liver metabolism is high in children until the time of puberty. And that means that medications might need to be at doses that approximate an adult dose. And so, you know, that in and of itself is complicated, but then also when children go through puberty, the metabolism gets back to, you know, a slower rate, and therefore lower doses would be necessary during that phase. And then you'll see, we're going to cover in a couple slides, that in depression treatment, the dosages have to start very low because of the high rate of side effects in children. So it's really a complicated idea in general, but this is a general rule or a generalization that higher doses are required prepubescent for pharmacologic treatment. The controlled studies are very, very limited. The book talks about how at one point the FDA did incentivize studies, but they were all conducted by pharmaceutical companies, and pharmaceutical companies have, have an inherent bias. So they may not have been as rigorous and are not taken as seriously as controlled studies by, by government entities or university entities. Okay. So many parents will fear that their children will end up becoming dependent on drugs that they are taking as children. So those fears are super, super common, but the data does show us that only 2 classes of drugs are actually potentially abused at the statistical level, and they include stimulants and benzodiazepines. And then even within that, when children are actually diagnosed with ADHD, the use of stimulants tends to decrease their risk of substance abuse when you compare that to drug abuse rates in untreated ADHD subjects. So let me read this third bullet to kind of paint the whole picture. So untreated mental illness does result in a higher likelihood of drug abuse, right? And so, it turns out that the thinking with stimulant abuse is that it is more likely a risk in people who don't actually have ADHD, but in people who actually have ADHD, they don't experience the hedonic effects or the joyful or the addictive rewarding effects of stimulant use. They mostly feel the reduction of symptom effects. Okay. And I left that slide in there, but that was just encouraging you to read the chapter. So stimulants used for treatment of ADHD include a list that is in the book, but the most common that you're familiar with are Ritalin and Adol. Generally speaking, they enhance dopamine in the prefrontal cortex. The prefrontal cortex is our attentional control center. And so it makes sense that, enhancing that functioning would allow children to better be able to control their attention. The mechanism of action is inhibition of dopamine reuptake. Okay, so you're familiar with that system, and hopefully you can picture that. And then additionally, amphetamines in particular promote the increased release of dopamine from vesicles. So there are 2 mechanisms of action there. One, stopping reuptake, so there's more neurotransmitter at the synapse, and then also promoting the increase of release from the vesicles, which are still in the axonal terminal. They have not yet fused, but that means that there's more neurotransmitter swimming around and then available for release. And I am going to correct this before I upload it, but just so you know, this headline here above Ritalin and Adderall called amphetamines is not exactly accurate. And so I'm going to have to go back and change that. Amphetamine, Adderall is an amphetamine. Ritalin is technically something else. So I will go ahead and change that in the slide to correspond to the book. And then I'm not going to do the pause right here, but I do invite you. This is not a suggested or required video because it's not an overview, but by any means, it's really just a short 2-minute neuroscience video on how the mechanism of action for amphetamine. But I will put it in Sakai, and you're invited to take a look at that. And then diagnosing depression in children. Again, I'm pulling out salient points here, but I encourage you to do the reading. So using the standard DSM for major depression in children, it fails. So it failed to accurately diagnose 76% of young children who were judged to be suffering with major depression, okay? So there are better ways, basically. And the book does walk through some of those. So, again, take a look if that's useful for you. I imagine you will get, through your treatment classes, a much more precise understanding of how to go about diagnosing depression in children. But I definitely wanted to pull this out of our text and highlight it. And then forgive all the text, but I'm going to go ahead and give you a couple of these studies that were brought up in the chapter that I thought were important. So there's this TAD study, which is looking at adolescents with depression, and they're ages 12 to 17. They definitely are diagnosed with major depression, and then they're assigned to 4 groups. And after 4 months, 35% of them, of people who receive placebo, show reduction of symptoms. Okay, so 35% of people getting placebo, meaning no treatment, sugar pill, show reduction of depressive symptoms. 43% of children treated with just CBT show reduction of symptoms. Okay, 61% of children treated with just Prozac show reduction of symptoms. And then 71% of children treated with both CBT and Prozac show reduction of symptoms. So the greatest reduction of symptoms being with Prozac and CBT, and then the second greatest with Prozac alone. Okay, so you know, it was a unique study. As I said, there are not lots of controlled studies in children, and so this one stood out, and it did have big effect sizes. That 0.8 and 0.6, these effect sizes are relatively large. So drug treatments were significantly better than placebo or psychotherapy alone. All right, so, but here is what I was talking about earlier. Treatment is started with low doses for the first week or two, and then if tolerated, gradually increased, because approximately 5% of children have a condition referred to as D26 hypometabolism, where this enzyme that's responsible for metabolizing the antidepressant is underactive, it's under functioning. Okay, and so therefore there are high levels of blood level of the drug and very significant side effects in these early days, and so they start with low dosage. I wanted to call your attention to this confound of, there's a relationship between bipolar and ADHD, and it's not that many kids with ADHD go on to be diagnosed with bipolar, or that many adults with bipolar were found to have had ADHD as kids, but that sometimes the symptoms overlap in a way that misdiagnosis can occur, and sometimes a treatment for ADHD could result in cycling that is a trigger for the bipolar symptomology. So I just wanted to alert you to this. So symptoms that are common to bipolar but are rare with ADHD include this list up at the top here. But however, if there is a family history of bipolar, or one of more of the following of these on the bottom, then what could have been misdiagnosed as ADHD might possibly be bipolar. So I encourage you to go back to that section in the chapter. It's kind of complicated, but I just think it's an important thing to have a general understanding of now, which is that there is this, there seems to be enough overlap between bipolar and ADHD that there's some level of misdiagnosis that could be problematic. So people who are being really careful to properly diagnose ADHD will make sure that they rule out this bottom half of symptoms so that they don't potentially trigger that cycling by treating the ADHD with a stimulant that then results in a manic episode. Okay, I hope that was clear. And then anxiety in children. So in particular with anxiety, it more so than even with depression in the text, that most children experiencing clinically significant anxiety are experiencing it because of a situational stressor. Okay, so parents going through divorce, exposure to violence, witnessing parent arguments, et cetera, and so they respond best to psychotherapeutic interventions. Okay, so thank you.